result of our research, the novel role of macrophage in helping IP antagonists to eliminate the metastatic breast cancer. We all know that the most challenging issue for breast cancer is the metastasis to other organs, causing more than 90% of the cancer deaths. Bone is the most common site for breast cancer metastasis. Bone metastasis not only result in the bone-related events, including severe pain, fracture, spinal cord compression, and paralysis, but also secondarily spread to other organs, in particular to lung. You can see that the local injected the MDA-231 cells in the tibia spread to lungs after 5 to 6 weeks in the mice. Therefore, the prevention and treatment of bone metastasis would be critical for the successful cure of breast cancer. The development of bone metastasis depends on the cancer cell-bone cell interaction, in which osteoblast produce some factors such as RUN ligand to attract a cancer cell to reside in the bone. The cancer cell educates the macrophage to support the cancer cell growth. The cancer cell also promote RUN ligand production by the osteoblast to destroy the bone. The RUN ligand produced is also stimulate osteoclast formation to destroy the bone. The factors released during bone resorption further support the cancer cell growth. Therefore, an ideal therapy for bone metastasis would be to kill the cancer cells and to block the cancer cell interaction simultaneously. In the past, we have identified that TRAP3, the TNF receptor associated factor 3, not only inhibit the bone resorption, but also maintain bone formation. RUN ligand induced TRAP3 degradation in macrophage to enhance the osteoclast formation to destroy the bone. TGBeta induced TRAP3 degradation in the mesenchymal progenitor cells to inhibit the osteoblast differentiation through degrading beta-catenin. So the genetic deletion of TRAP3 in either mesenchymal progenitor cell or myeloid cell result in early onset osteoporosis. Therefore, stabilization of TRAP3 would be a new strategy to inhibit the bone resorption and stimulate the bone formation simultaneously. To find out the approach that stabilizes TRAP3, we focus on a class of E3 ligase inhibitor of apoptosis protein, which are endogenous inhibitor of apoptosis. IP proteins include 8 members, such as the CIP1, CIP2, and XIP. It is known that TRAP3 form a complex with CIP1 and CIP2 to induce TRAP3 degradation, resulting in the non-canonical NLRP3 activation. A large number of IP antagonists that degrade IP protein have been developed. From a number of IP antagonists, we identified that SM164 inhibit osteoclast formation and promote osteoblast differentiation by degrading CIP1 and CIP2, therefore increase TRAP3 protein level in the macrophage and the myeloid progenitor cell, in macrophage and the mesenchymal progenitor cells simultaneously. The IP proteins are commonly overexpressed in cancer cells, promoting cancer cell survival and growth. Several IP antagonists have been done clinical trial to treat cancer, but the benefit of this IP antagonist to cancer patients is very limited. We found that the IP antagonist alone, including SM164, 86, 8406, couldn't kill the cancer cells in vitro, even given a higher dose. However, In the presence of low dose of TNF, low dose of IP antagonists strongly induce the apoptosis of the cancer cells. Of note, SM164 is 30 to 100-fold stronger than BB6 and AT406 to kill MDA-231 cells. SM164 kills the cancer cells starting around 1 nanomolar, while BB6 starting around 30 nanomolar. Among the IP antagonists, SM164 most effectively degrade CIP1 and CIP2 in MDA-231 cells, at least 100-fold stronger than BB6 and AT406. You can see that CIP1 and CIP2 protein level were completely disappeared in the cell treated with 3 nanomolar SM164. In contrast, CIP1 and CIP2 protein level are still present in the cell treated with the 300 nanomolar of BB6 and AT406. Of note, TNF markedly increased the CIP1 and CIP2 protein level, which can explain why TNF alone doesn't kill the cancer cells. So in this summary, the SM164 can inhibit osteoclast formation, stimulate osteoblast differentiation, and strongly kill the cancer cell in vitro. Therefore, it could be used to treat breast cancer bone metastasis. To test the hypothesis, we inject the MDA-231 breast cancer cell into the heart of the new mice. From the second day, the mice were given the following 3 treatment vehicle, SM164 alone, and standard chemotherapy, including doxorubicin, cytoxan, and zometa. Tumor growth was assessed using bioluminescence imaging every week. You can see that both SM164 and standard chemotherapy significantly reduced the BLI signal in the legs after 1 through 4 weeks, while SM164 had a better effect than the standard chemotherapy to inhibit the tumor growth. Mice were euthanized after 4 weeks to examine the metastasis by histology. We can see that all the 7 mice treated with the vehicle had bone metastasis. Only 2 of the 8 mice treated with the SM164 had bone metastasis, while 5 in 7 of the mice given standard chemotherapy developed bone metastasis. When we count the number of individual bones with metastasis, including the tibia and femur, SM164 reduced the number of bone with bone metastasis to 9% compared to 60% of the vehicle and 40% of the standard chemotherapy. Impressively, none of SM164 treated mice had lung metastasis, while 68% of mice treated with the vehicle had lung metastasis. We also found that standard chemotherapy didn't have effect to prevent the lung metastasis. We also evaluated the effect of SM164 on the treatment of established bone metastasis. The treatment began 2 weeks after cancer inoculation to the heart. We found that neither SM164 nor standard chemotherapy had the effect on the number of bones with established metastasis, but both reduced the tumor burden in the bone. They also had trained to reduce the lung metastasis, but didn't have the statistical difference compared to the vehicle. In summary, in this part, SM164 can effectively eliminate the early stage bone and lung metastasis from MDA-231 cells, but it has no effect for the treatment of late stage bone metastasis. although it reduced the tumor burden. We asked that how SM164 kills the cancer cell in vivo, provided that SM164 alone does not kill the cancer cell in vitro. Macrophage is the most abundant cancer supporter cell, accounting for 30% of all cells in the cancer. It also is the major source of TNF. Macrophage is classified as the inflammatory M1 and resident M2 macrophage, linking to Th1 and Th2 immune response respectively. TAM mainly inhibits the phenotype of resident macrophage, which is mainly polarized by IL-4. We generated the macrophage from mouse bone marrow cells and polarized with them with IL-4. Then we performed the co-culture of the macrophage with MDA-231 cells to test the apoptosis of the cancer cells by the flow cytometry. You can see that in the presence of the SM164, IL-4 alone without the macrophage didn't kill the cancer cells. Addition of the naive macrophage slightly increased the apoptosis of the cancer cell, which was further increased by addition of IL-4 polarized macrophage. You also can see that TNF inhibitor blocked the apoptosis of the cancer cell induced by IL-4 polarized macrophage and SM164. We have discussed that SM164 kills the cancer cell in TNF-dependent manner, while SM164 alone failed to eliminate the established bone metastasis. Is this caused by that TNF level is not high enough in vivo? Can we use TNF to help SM164 in treating the established bone metastasis? Address this question. We compared the effect of SM164 plus TNF with SM164 alone for the treatment of established bone metastasis. Starting at day 15, when the cancer cell have established in the bone, shown by the BLI signal, we treated these mice with vehicle SM164 alone, SM164 plus TNF and chemotherapy. You can see that half of the bone metastasis disappeared after the treatment of SM164 plus TNF. In contrast, neither SM164 alone or standard chemotherapy eliminates the metastasis, although the tumor burden was reduced. Impressively, SM164 plus TNF completely eliminates the lung metastasis, while SM164 alone or the standard chemotherapy didn't have the effect to prevent the lung metastasis. To further determine if macrophage producing TNF is critical for SM164 in treating bone metastasis, we added the TNF antibody or coordinate to SM164 treatment. MDA-231 cells were directly injected to the tibia of the NSG mice. After 2 weeks, we began to treat the mice with the following 5 groups: vehicle, SM164 alone, SM164 plus either TNF, TNF antibody, or cloronate. Cloronate can effectively deplete the macrophage. As the BLI signal showed, SM164 plus TNF significantly reduced the tumor growth. In contrast, addition of TNF antibody or cloronate stimulates the tumor growth in the bone compared to SM164 alone. Micro-CT scanning showed that SM164 plus TNF protect the bone from cancer-induced osteolysis. Addition of TNF antibody seems to worsen the osteolysis compared to SM164 alone. Addition of a cloronate still protect the bone from cancer-induced osteolysis, although it increased the tumor growth because clotronate can deplete macrophage to inhibit the bone resorption. We also test if TNF can enhance the effect of SM164 on the treatment of bone metastasis from ER-positive breast cancer, because bone metastasis most commonly occur in ER-positive breast cancer. CF7 breast cancer were directly injected to the tibia in NSG mice. After 2 weeks, the mice were began to treat with the sixth group in the vehicle TNF SM164 alone, SM164 plus either TNF domator or TNF antibody. At baseline, before the treatment, BRI signal in the bone didn't have among the groups. After 1 week treatment, only SM164 plus TNF had the effect to reduce BRI signal in the bone. After 3 weeks of the treatment, BRI signal in the bone treated with TNF is higher than those treated with vehicle. The BRI signal in the bone treated with SM164 plus TNF is still lower than any other group. You also can see that SM164 treated the group in some mice, some bone have reduced the BRI signal. However, if add to the domator, none of the bone have reduced the BRI signal. In summary, macrophage produce TNF to trigger breast cancer apoptosis induced by ILP antagonist. SM164 can eliminate early but not late stage metastatic breast cancer because the level of TNF is not high enough. TNF in combination with ILP antagonist is more effective to treat late stage metastatic breast cancer. However, TNF may cause severe side effects in humans. The question is that how can we translate this finding to the clinical setting? Our findings suggest that ILP antagonists should be given early because they fail to eliminate the later stage metastasis. We ask that how early the ILP antagonist should be given. The chemotherapy is often used after surgery, aiming to eliminate the metastasis on the circulating cancer cell to prevent the development of metastasis and the recurrence of the cancer. A major issue is that the cancer cell can develop multi-drug resistance, resulting in the failure of cancer treatment. We ask that if multi-drug resistant to chemotherapy influence the effect of ILP antagonist therapy. We established Dox-resistant MDA-231 cells to test if SM164 can kill it. As expected, Dox-resistant didn't kill the resistant cancer cells. SM164, even given a high dose, didn't induce the apoptosis of Dox-resistant cells in the presence of TNF, suggesting that Dox-resistant cells is also resistant to SM164. We also established the SM164 resistant MDA-231 cell to test if Dox-resistant can kill it. As expected, SM164 was less effective to kill SM164 resistant cells. Interestingly, SM164 resistant MDA-231 cells are sensitive to Dox-resistant, similar to their parental cell, suggesting that SM164 doesn't induce the multi-drug resistance. RNA-seq analysis show that the expression of MDR1, 2, 3 genes are significantly increased in Dox-resistant resistant, but not SM164 resistant breast cancer cells, confirming that Dox-resistant induced multi-drug resistance, but SM164 doesn't. So we conclude that ILP antagonists should be given to a patient before and ideally followed by conventional chemotherapy, because the conventional anti-cancer cancer drug can induce multi-drug resistance, while IP antagonist doesn't. Macrophage produced TNF in tumor microenvironment is important for IP antagonists to kill the metastatic breast cancer. An addition of TNF enhances the effect of IP antagonists to treat the metastasis from TNBC and ER-positive breast cancer. A bisphosphonate shouldn't be given together with an IP antagonist to a patient, but can be given after IP antagonist therapy, because bisphosphonate can kill or inhibit macrophage producing TNF to counteract IP antagonist to treat breast cancer metastasis. I like to stop my talk here. Thank you for your patience.